Welcome, everyone. We'll get started in just a moment. Please take the time to introduce yourself in the chat, and we'll get started shortly. Hi, everyone. Again, thank you so much for joining us today. We're the New England Mental Health Technology Transfer Center. We have Anthony Pavlo with us today. I will be handing it off to him soon, but we'll just start with a few housekeeping items and a brief introduction of our center. Next slide, please. So just with the housekeeping information, participant microphones will be muted. And during the presentation, if you do have any questions for the presenter, you can raise your hand. It will unmute you during the presentation, or you can always use the chat. This event is being recorded and it will be on our website tomorrow. I will be sending an email to all of the registrants with that information. And if you do have any questions after today's session, you can always email us at newengland@mhttcnetwork.org. Next slide, please. This is just our disclaimer. The presentation was prepared for the New England MHTTC. We are funded by SAMHSA. Our grant number is down at the bottom. Next slide, please. And the MHTTC network uses affirming, respectful, and recovery-oriented language in all of our activities. And the language you can see is on the screen. All of this information will also be on the PowerPoint slides that will be posted on our website. So you can read this in more detail if you'd like. Next slide. And so the New England MHTTC, our mission is to use evidence-based means to disseminate mental health evidence-based practices across the New England region. Our area of focus is recovery-oriented practices, including recovery support services within the context of recovery-oriented systems of care. Next slide. Our guiding principles, which are resilience and recovery and all of its pieces. Again, this will be on our website posted so you can read this in more detail. Next slide, please. So today's presentation will be respect, collaboration, and shared decision-making, a relational approach. It will be presented by Anthony Pavlo, and I'll just do a brief introduction about him and hand it off. Next slide. Thank you. So Dr. Anthony Pavlo is a clinical psychologist and an associate research scientist at the Yale University Program for Recovery and Community Health, or PERCH for short. His research focuses on recovery-oriented and person-centered practices in mental health care, especially the role of collaborative relationships in care. So with that, I will hand it off to Dr. Pavlo. Thank you.
Hi, thank you. And thanks for having me, and thanks for everyone for attending today. As Vanessa said, please feel free to jump in and ask questions. I will also leave some time at the end, but I am happy to make this as interactive as possible. So as Vanessa said a little bit, I will today be talking about shared decision-making. So I'll start a little there in the history of shared decision-making and how it fits into the sort of current healthcare landscape. I'll talk a little bit about what brought me to this research and specifically my training as a psychologist. And then we'll talk a little bit, I'll talk a little bit about my own research that aimed to develop a tool to help doctors and clients collaborate and to make decisions together. So I'd just like to acknowledge that my mentors on this project, which are Larry Davidson, Marie O'Connell, Steve Olson, and Mary Snyder, that project really couldn't have happened without their help, support, and mentorship. And this was originally funded by the Agency for Healthcare Research and Quality. So I just want to say that too, as part of an early career award. So I want to start with kind of the why here. So actually, before I get there, I will say that will be focused on shared decision-making in psychiatry, particularly for people with serious mental illnesses and particularly psychosis. I think that's important. The reason I want to say that is because I think people who often receive those labels often don't have the opportunity to engage in shared decision-making or aren't given that opportunity. Which leads to all sorts of negative outcomes. So for me, the big things here are there are significant disparities when it comes to access, when it comes to quality of care, and then when it comes to outcomes. I think a lot of this has to do with stigma and discrimination in mental health care. I know we often talk about sort of stigma and discrimination in the community, but there's more and more research supporting this idea that the stigma does sort of exist in mental health centers in themselves. And I think this manifests often as lack of options and choice. This idea that people with psychosis can't benefit or can't engage in meaningful therapeutic relationships, which we'll talk about some more, as well as education and training, and particularly for relational skills. I think much of my argument here is based on the idea that relationships are some of the most important parts of treatment. Yet we don't really give them very much attention. They tend to be seen as kind of haphazard, or our training is kind of haphazard around them. And often we've all heard things like there are certain people that are good at engaging clients. I will switch back and forth between clients and patients, mostly because shared decision-making really has to do with decisions made with doctors. And I'm really talking about role here, so I will switch back and forth between the two. But I think what my main point here is to say that we can approach this in a more rigorous way, so that all people have the opportunity to engage in shared decision-making. So I see shared decision-making as one aspect of person-centered, recovery-oriented care. I don't think it can solve all of these problems, but I think it's an important piece or an important tool in our toolbox. So as you may know, person-centered care really emphasizes agency, choice, and self-determination, and really placing the person at the center of their care, right? So what's important to people? What are their values? What are their goals for treatment? What are their preferences for treatment? Person-centered care really attempts to put these at the center and make decisions based around this idea, which really is in stark contrast to the delivery of medical care before. The next piece is just recovery-oriented care. And this is the idea, again, as you might know, that the idea that people, regardless of whatever condition they should have access to a meaningful life that feels satisfying to them in the community. And I think shared decision-making can really help support that for people. So we often hear about sort of peer work, things like person-centered care planning, advanced directives, which I'll talk about a little bit. And I also think about a citizenship framework, which emphasizes rights, roles, responsibilities, resources, and relationships. So that's just a little bit of a context where I think shared decision-making sort of fits in. And as we know, like, as I said before, there are fairly huge health disparities for people diagnosed with serious mental illness. There is a massive disparity in life expectancy, about 20 to 25 years, and a host of comorbid medical conditions that are not treated or well managed. So people are 2 or 3 times more likely to have diabetes, 6 times more likely to die from cardiovascular disease, 2 or 3 more times likely to have a stroke, 2 to 6 times more likely to die from respiratory conditions, and overall are just more likely to die because of chronic conditions, chronic comorbid conditions. The way this is often laid out in the literature is there are certain individual factors such as lifestyle, like lack of physical activity or poor nutrition. There's also the side effects of many psychiatric drugs, especially for psychosis and SMI. The second big area here is the social determinants of health. So things like homelessness, housing insecurity, food insecurity. And the last is I would say are sort of inadequacies within the healthcare system. So we have a fairly fragmented healthcare system that doesn't well manage people with multiple conditions, especially multiple chronic conditions, as well as a system that medicalizes mental health concerns that often neglects the whole person and context. And finally, stigma, which I will talk about a little bit more later. So shared decision-making on the surface seems fairly straightforward. The idea here is that doctors and patients will come together to share responsibility for decisions and make decisions together. The way this is often talked about is that doctors and patients, and again, I am using doctors and patients here, but I do think this applies to, I'm a psychologist, I think this applies to any mental health or anyone working in healthcare. But much of the shared decision-making literature focuses on decisions made with doctors because those are the sort of big capital T treatment decisions. So shared decision-making is often said to be for doctors and patients to engage in a collaborative practice to share these decisions. However, the link really between the two is not really well studied. I think there's the assumption that everyone can engage in collaborative relationships and the shared decision-making should just flow through that fairly simply. But as we've seen, I don't think we really know or have really well articulated what these sort of key relational features are, which is what the work that we've taken up here. Some have referred to shared decision-making as this neglected second half of the consultation. It acknowledges sort of two experts, one with an expertise in medicine and the other with sort of an expert on their own experience. So shared decision-making has its roots, and this is something that's beyond psychiatry, and in many ways, other specialties are far beyond psychiatry when it comes to implementing and using shared decision-making. But there were attempts in the 1980s to ensure that patients were giving true informed consent for the treatments they were undergoing. And what was realized that the patterns in place and not the patterns, but the ways decisions were made up until that point weren't really adequate to ensure that people could give true informed consent. And the second is the sort of the roots of person-centered care, also around the same time. So initially, shared decision-making really required a shift in the role of the patient, the doctor, as well as the relationship between the two. So the patient was no longer the sort of passive that medical care is done to, but it was more of an active partnership between doctors and patients. Patients are seen as active and the deciding agent here. So in my view, shared decision-making really had the potential to radically redefine how people related to each other in healthcare settings. I don't think I think this research has been going on for about 30 years, and I don't think we've really realized its true impact just yet. There are a host of ethical justifications for shared decision-making, in that it feels like the way to really ensure that patients are involved and aren't being coerced. There's again a bunch of empirical justifications. So enhanced the use of shared decision-making has been linked to enhanced clinical and patient-centered outcomes. Some have argued it's cost-effective, and it may be particularly effective in the care of chronic conditions. Shared decision-making is often seen as a way for especially helpful in situations where there isn't a clear treatment, where there are many risks and benefits. So it's really taken off in places like oncology, for instance. But I think this is exactly the same situation we face when we're thinking about mental health treatment for people with serious mental illnesses. We all know that there isn't one drug that fixes everything. There isn't one treatment that fixes everything or one therapy that fixes everything. And it really is, there really is an art form to it. And I think shared decision making can help serve as a bit of a framework for people. It was adopted into the Affordable Care Act, as well as a host of other patient-centered principles. There's an increased pressure on providers to engage in shared decision-making, even linking reimbursement to shared decision-making going on. But there really has been a pretty widespread failure to implement shared decision-making in everyday routine care. So this is the way decision-making and shared decision-making specifically is laid out in the literature. There are said to be 3 different styles of decision-making. And these were the paternalistic one, the shared, and the informed model. These are said to exist along a continuum, right, from paternalism to informed. And they're broken up into 3 different categories. There's information exchange, deliberation, and who ultimately decides. So this is a bit of, I'm going to talk about extremes here. So this is a bit of a caricature, but the paternalistic model, I think we're all fairly familiar with. It's doctors are telling patients what they should do, and it's patients' responsibility to follow their doctor's orders, basically. In terms of information exchange, there's often this one-way flow of information, right? Doctors aren't very much eliciting patient preferences here, but really providing medical information. It goes from the doctor to the patient. It tends to be entirely medical. And in terms of the amount, it's usually a legally required minimum amount. Again, going back to this idea about informed consent. The doctor alone makes the decision about the care, about the course of treatment, sometimes in consultation with other doctors, but not necessarily with the patient. And the doctor is the one who ultimately decides what the care, what the treatment course will look like. In the informed model is much, I think, is a more common, maybe not more common, but I think a little bit more in vogue these days. It's much more of a consumer model of decision-making. In some ways, while it is very different in that the patient is the one who's ultimately deciding, there are some ways that it's similar to the paternalistic model, as you see here. So there is still this one-way flow of information from doctor to patient. It again tends to be entirely medical. However, it's really anything relevant for decision-making. So anything a person would need to know about, let's say, an antipsychotic medication, risks, benefits, what the literature says about the specific one, matching it with personal individual characteristics. So the doctor here is really sort of an educator, right? I'm going to give you all the information you need to know to make a decision. Deliberation happens on the patient's side alone. Maybe they're often with family members or significant others, maybe not. And the ultimate decider here is the patient. Some have argued that this can be a bit sort of abandoned patients in a lot of ways. There's medical information is really hard to sort of wade through if you don't have that knowledge. And people often describe feeling fairly lost in many of these treatment decisions when left in this way of thinking. Shared decision-making sort of sits in the middle here. And the idea, so in terms of information exchange, this is where really things are very different. So there's a two-way flow of information from doctor to patient and from patient to doctor. And it's not just medical information, but it's medical and personal information. So anything, again, here is anything that's relevant for decision-making, but a doctor might ask patients what their preferences are for care, or even their preferences in terms of decision-making. Not everyone necessarily may want to engage in this kind of decision-making, maybe wants to be told what to do, or they want to do their own research and figure it out and then come back. So it's eliciting a lot of these kinds of preferences and hearing from patients about what's important to them, what do they want to do in their day-to-day lives, what are their goals for care. And at the same time, also providing options and medical information. That doctors and patients are supposed to, the idea here is that doctors will support patients and help them make decisions together. So this is the collaborative process. And ultimately, doctors and patients should agree about the treatment outcome. I'm going to talk about this a little bit more later. I think there's so in most of medicine, information exchange has been really focused on to the exclusion of all these other things. So you'll get a lot of ways to educate patients or these decision tools that provide all the different information and help people walk through the decision they're trying to make. While this is really, this first area has really exploded in the rest of medicine, it's still pretty scant in psychiatry. But there are some tools, especially for antipsychotic medication or for just deciding about medication in general. But I think there's also problems with this model in general, like the idea that doctors and patients should agree when it's really the patient that's living with a condition 24/7 and is making decisions about their life and living their lives. So, but I will talk about that a little bit more. Some of what's been out there, most relationships haven't really been talked about, but people have started to sort of address these things. So some people have talked about splitting shared decision-making competencies into relational one and risk communication. Much of decision-making in medicine has to do with risk, right? Like how much risk is a person willing to take on for a certain treatment. So the relational ones are really just sort of setting a frame in a lot of ways. So developing a partnership with a patient by inviting them to participate. So just a simple invitation to participate in treatment decisions. Like I said before, identifying the patient's preferred role in decision-making, eliciting fears, questions, expectations for treatment, questions and concerns, and then things like generating a concrete plan around arranging for follow-up and things like that. When it comes to risk communication is really just about talking about the various ways that each treatment option that is open to the person, what are the pros and cons, basically. But the hard part here is doing this in a way that isn't directive, as the first bullet says. Really figuring out how patients want to receive information based on a variety of things, including educational levels, health literacy, things like that. And then as well as their own culture and background and how medical care is seen in that way. Similarly, other people have talked about this collaboration talk model, which has sort of three components to it. There's this sort of team talk or choice talk, which is again, just highlighting that options do exist and opening up the door for shared decision-making. There's option talk, which is really just providing medical information, but really providing these concrete ideas, concrete paths. And then decision talk, which is focused on supporting patients in making decisions. The idea here is that this is just to highlight the different kinds of dialogues that could happen in a consultation and just to make that easier for clinicians. There's a ton of barriers and facilitators that are identified in the literature, like time pressure, which comes up a whole lot, that it's not applicable to certain patients, that it's may not be appropriate for certain clinical situations. And then there's just perceptions of patient preferences and characteristics. Some of people have said it's too rigid. But really the facilitators here are really the idea that this is a good idea, that shared decision-making will lead to better positive patient outcomes, will lead to better patient experiences. From our own research, we've started to identify some other barriers that aren't often talked about that much. The first being that while shared decision-making still tends to be pretty doctor-centered rather than patient-centered, it really is a sort of very medical model way of knowing and prioritizing different kinds of information or different levels of experience for patients. And it's more about ceding power than really sharing it. So I think that is one sort of huge barrier here. I have talked about the second bullet point, but just there's a lot more research and implementation of the ways to sort of educate patients about certain diseases or conditions, but not necessarily supporting them in sharing a decision making, sharing a decision. And then there's all these things like health literacy, decision support, enhancing communication and ways to do that. So really what the question that we decided to focus on was what kinds of relationships are needed to facilitate and sustain this kind of decision making. Oh, there's one more thing here. And then there's stigma. again, while I said before, we often will talk a lot about community stigma. There's more and more research to support the idea that there's also stigma within the mental health care system. And particularly for shared decision-making, I think there's a lot of justifications for paternalism, which is a real thing. There's a certain amount of risk involved. That makes sense. But at the same time, people should be able to engage, choose what's going to happen to their own bodies. And I think much of the justifications for paternalism are based in an illness model. So there's this idea that sort of stems from the early days of psychiatry and psychoanalysis that people with psychosis can only engage in them very limited types of relationships. They have poor reality testing and insight, poor judgment. They're often non-compliant or non-adherent. And often patients' levels of dissatisfaction are not really taken seriously, or distrust is not taken seriously, and instead is talked about as sort of part and parcel of someone's condition. So, and I think for most people, in our day-to-day lives, we know this isn't necessarily true. We've all had the experience of having, I'm sure, pretty rich relationships with people with these diagnoses, but this is often how it gets played out, I think. So before I move to the next sort of section here, I just wanted to stop and see if there are any questions, or I know I'm kind of moving kind of quickly. So please let me know if you have any questions or if anything's not clear at this point. Okay, I'm going to continue a little bit. So I am a clinical psychologist, a therapist by training. I was had the opportunity to attend a graduate program that really focused on pluralisms, this idea that all psychotherapeutic approaches had value. So we learned about anything from Jungian approaches to CBT to community psychology. But what was something that was very interesting to me was this idea of common factors. So in the psychotherapy world in the 70s or so, there was all these new different kinds of psychotherapies being developed. So the question started to come up, like, how do we know which one, what works better? And if there are so many, we need to sort of find a way to sort of test this out. What they found was that whatever orientation you're using, whether you're using cognitive behavioral therapy or psychoanalysis or humanistic therapies or cognitive behavioral therapies, the outcomes were all about the same. People benefited from all, which led to this idea of common factors. So there must be these sort of unifying common factors across psychotherapies that are helpful to clients. This again, many people know Carl Rogers. He is one of the sort of first people, one of the early humanistic psychologists in the 50s and 60s, and also one of our first psychotherapy researchers. And in one of his early papers talked about the sort of necessary and sufficient conditions for people to change in psychotherapy. Not one of them had to do with technique or the actual treatment being delivered. Much of it had to do with therapists not only experiencing, but effectively communicating things like empathy and unconditional positive regard. So what I mean by that is that not only so if it was me and not only experiencing that I have some understanding of what this person's world is like, but also communicating to that, and they can hear it, and they hear it, right? So I can feel like I'm being empathic, but if the client doesn't experience it that way, it doesn't matter. I think two of my favorite resources in this area are one fairly new book by David Elkins named The Human Factors of Psychotherapy, which outlines some of these things, which I will talk about, and Art Bohart's work on the active client. I'm going to skip over, let me go back a second. So the idea here really is that when they did these studies, they found that the treatment that someone was using, so like if it was CBT or if it was a psychodynamic approach or a humanistic approach, accounted for a couple percent of change in psychotherapy. What accounted for the most was the person themselves, who they were, where they were coming from, and things they were doing outside of the therapy room. The next big factor was what are called sort of non-specific factors or relationship factors. Things like, is there a good match between therapist and client? Some of these things I mentioned before with reference to Carl Rogers. So this is sort of where the background that I come from. And so it sort of led me to think, so what lessons are we sort of learning from all of this? One is we may not be as important as we think we are. And I say that jokingly, is that it's the treatment itself is only effective in the context of a healthy, strong therapeutic alliance. I think the things that tend to get in our way are things like these expert models or sort of drug metaphor in psychotherapy. But I won't talk too much about that. That's not relevant here. So we know techniques have very little to do with outcome, that the relationship appears to play a much larger role than technique. The client is the largest factor. So it really is pointing to this idea of what is a healthy sort of therapeutic environment for people. And I was going to say one more thing and I lost track of it. I'm sure it'll come back to me. But while I know that this can't be sort of imported wholesale into medicine, there's in some ways, because it's not just, while psychotherapy is complicated, it's one part of medical treatment, or we don't have to see it that way, but in traditional context, it is. So, yeah. So now I'm going to move on to talking about the research that we've done, which was what we aimed to do was develop a tool to help support collaboration and help clients and therapists build collaborative relationships in medicine. This research was done across in primary care centers and community mental health centers. We wanted to get sort of the range, and we thought there was some similarities. There were some similarities and important differences between primary care and community mental health, but often people are also facing similar issues. So we thought this is why we chose these two groups. It was a participatory project, so the idea here was to engage stakeholders in a variety of ways, and we did so in two. The main one was to bring together a group of 3 people with lived experience of serious mental illness and chronic physical conditions. We met weekly. They helped with every aspect of the project, decision-making about how we should do things, analyses, writing things up. Before we did our own interviews, we looked at some data that we already had where people were talking about their relationships with providers. And we looked at all this data just to get a sense of what area should we be asking about. Relationships are in some ways very easy to talk about, but also very hard to talk about in a rigorous way. So we really wanted to make sure we're asking the right kinds of questions. And lastly, we used concept mapping, which is a really nice approach to not only visualizing data, but analyzing data in a way that you can have very little knowledge of stats and be able to do pretty high level statistics for one, and be able to do it with a range of stakeholders. So people with very little stats experience and maybe some that has a lot more. So this was really great for us. I should have said the other way we engaged stakeholders was to have a bigger advisory board that was made up of family members and patients, clients, and doctors. So it was really helpful in these mixed groups to be able to run these analyses and find the best way to think about a tool and a measure, and doing so in a participatory way. So we did about 42 interviews split across doctors and clients and patients. And I said we did this in community mental health, primary care, and primary care. So I was hoping want to give you a bit of a sense of a sort of a feel for what people were saying and some of the sort of barriers I think we're up against um, when thinking about shared decision making. Like I said before, and on the surface, it feels like a fairly straightforward, simple concept, but it gets fairly complicated once you get into the idea of implementing it in an everyday, routine way. So let's talk a little. I wanted to show you some quotations from the interviews with physicians first. Some of these are from psychiatrists and some are from primary care. This is a person, I'm not going to go read, this is not one I'm going to read through. Just the idea here is that this person has a really clear method for figuring out how people are taking in information and if they're understanding it, which is something they do this like idea of a ask, tell, ask, right? So they'll ask what people know about a certain condition, inform them, see what their level of understanding or knowledge is, fill in that information, and then ask for what often is called like sort of a teach back, and have the person sort of describe back how they understand it, just to ensure that this is happening. I think this also comes from primary care, and I think it's important. So this person says, so I asked the patients, they've come to me, they've been referred, what is they understand they're suffering with, the background for what has led to that understanding. I think out loud in the language of the patient, so it's an active translation. The diagnosis may be threatening, so I'm thinking out loud in the language of the patient. I present them facts, and it's important for me to elicit from them that they evidence understanding of what it is that I have told them. Because one can discover you come to the end and the patient is shut down because of the burden and the threat or the fear of what, or the implications of what it is I'm attempting to communicate. So it's as much as listening as it is talking. Which I think is really important and well said. I think the problem is, earlier I was talking about stigma, and the next few slides I think start to address this, or at least and sort of demonstrate some of the confusion people have when trying to implement more person-centered practices. So this person's talking about the sort of a diagnosis that someone comes in with. They might have a diagnosis, doesn't necessarily mean they've been told about it. So this person says, I have to say, I don't necessarily bring it up. I might, depending on the patient. So if the patient is someone who's really aware, seems to be educated about their illness, then when I'll ask them, so the chart says you have whatever diagnosis, what do you think about that? Are you aware of that? Have you been told that? If it's psychotic patients, that's the population I see the most. If they're actively paranoid of seeing me or cognitively they're quite impaired, then I personally don't see the point in hashing out the diagnosis with them unless they ask. Which is why I said before, in other specialties, such as oncology, for example, information exchange, that area has really exploded. But I think because of, this hasn't happened to the same level in mental health care. I think the difference I was seeing in psychiatry, or we were seeing in psychiatry and other places, or not just psychiatry and other places, but just among different providers, was some took an approach that patients should always be involved and they were going to figure it out. Sometimes I was limited depending on what the patient was coming in with, but it was always on the table. And then there were other ones, which I think this quotation exemplifies, where there's a conditional aspect to it. I'll engage in shared decision-making if there are certain things in place. This person lays some of them out at the end, but they tend to be kind of fuzzy, and usually people are working from sort of the gut level here. I'm going to skip this just because of time, but again, here's the same thing. The person feels that the diagnosis of schizophrenia is stigmatizing, so it doesn't tell people the diagnosis in fear of that, of hurting them. I just like this. I think it's really well said. I don't know how to reconcile being patient-centered, but at the same time, patient-centered, respectful of their wishes, and that their wishes would reflect their needs. I don't know how to reconcile that with quote unquote insight. And then there's things that are for somewhat more extreme. Because this person gets so sick, I'm not even interested in their desire to get off medication. So for clients, I think we heard, it was quite amazing. We heard a sort of range of stories from these very positive experiences where patients described how particular clinicians and providers had saved their lives in many ways. Talked about this caring relationship where they felt like they were supported, they could ask questions, they felt, it was really that they felt someone cared for them. However, the majority often were not. So this is one example. So it's a beautiful feeling. I think that, he saved me from myself for the fact that he didn't allow me to hurt. He made me feel like I could be safe with myself, and that, I didn't have to act out because I was feeling unsafe. And the importance of creating a safe environment for people to engage in shared decision-making is, I think, one of the most important pieces here. The next two really have to do more with hope or the lack of it, and how this often gets transmitted in mental health care. So, I mean, you're going to do what I say. And I think that, feeling like you're hopeless when you walk out of the clinic just snowballs in the community. If I feel like I didn't get any help while I was here and I walk back out there, then I knew there's nothing else that could be done out there. It's just in the same vein. I'm being violated, and he's not really that concerned. I don't really feel like he's really hearing me out. And then the distress comes in, and how do I move forward from that? I guess there's a part of, I guess there's a part of me that says, whatever, just take the pill and hope everything's all right. Again, not only does this not, I don't think this is how we want people to walk away from an appointment, but it is not an example. It is not a way that doctors and patients are being clear and honest and transparent with each other. It's just sort of saying, well, I hope this goes fine, and going with it. This next one I find very troubling in a lot of ways. I think it gets to the mistrust that often is felt by patients. Well, I mean that if I'm in a delusional state and I'm having my symptoms are so that I'm so delusional, that's not something I want to communicate with the doctor. Because he might just decide that, I don't need to be in public, right? So some things, if my psychosis is that bad, then I wouldn't tell him that. From learned experience, I suppose. I mean, this is, sort of a clear example in many ways of if this would be the time to speak to the person that's supposed to be helping you with these types of issues, and you're not, if the idea of not telling a doctor what symptoms you're experiencing is highly problematic. I'm going to skip a couple of these. But before I do that, the other thing that was very interesting in these interviews was that while we often earlier I talked about non-adherence or adherence and non-adherence, we often sort of talk about people with schizophrenia and other serious mental illnesses that rates of adherence are low. People often, we talk about revolving doors quite often, but what was clear in all of these interviews were that people were, and we don't really talk about the reasons for that. We say it's part of their illness and they don't understand how sick they are, so they walk away. People often described a much more conscious, rational process for stepping away from treatment. That often had to do with the subtleties of it. Not always. Some of these, I've chosen examples that are a bit or less subtle, but it was more subtle. These subtle ways people felt invalidated, felt that they weren't part of their care. And they would talk about how these things led to walking away from treatment. Let's skip this one too. In the same vein, we also heard quite a bit of people just not feeling like they could be honest with their providers and instead had to play sort of a game to get what they wanted. So this person was talking about an inpatient hospitalization. And he said they were trying to give me a certain medication one time. I started the medication, but I kept getting ill. And I said, this is the medication, it's the medication, it's the medication. what's missing here is that the person had been on this medication in the past and had had fairly negative side effects from it. The doctors were saying, you hear voices, you need to take the medication. I said, it's making me ill, and he wasn't going for it. And the only way I could get them to change it is to tell them one of the side effects that I wasn't even having. And he finally decided to change the medication. And so to navigate through some of this in an intellectual way, we'll have to say, yeah, I've learned to get through how to manipulate the system to work it to my advantage, as you say, play the game. Skip this one. The other thing that came up quite a bit was just changes to treatment without any input from the person, right? So this person says, and sometimes I think me as a consumer is left out of the conversation between them sometimes, between them being the doctors and their care team. And that doesn't always sit well with me either. And that, it's also that, they'll make a change in your medication and they won't always tell you why they do it, their thoughts about it. And then you go to the pharmacy and you find out your scripts have changed and and why didn't he tell me this? So it wasn't even something discussed. They just show up, get a medication, and it's a different one. This was not a one-time story. This happened we heard this time and time again. This again, people often felt like express a lot of confusion, right? If you're doing well, if you're not having side effects from a certain medication, why change it? And this was a big question for people. There was one person that talked about starting to have a movement disorder, but wasn't told this is why the change was being made. And so felt very let down by the system, very left out, until a couple months later when they did find out that that's why the medication change was happening. People talked a lot about being overlooked. I'm going to skip this just for time. I think it's interesting. We always, when we talk about psychotherapy, when we talk about delivering any kind of treatment, we often talk about how patients need to trust us for therapies to work. It was what we were saying much more was a sort of like this idea of that trust is mutual or reciprocated or reciprocal in some way. Or like this person says, for people to feel empowered, they often had to not trust their doctors at all. Or not at all, but not trust their doctors and just rely on their own judgment. Again, this person, I think this is the same individual who is also a substance abuse counselor, who was just finishing up school to be a substance abuse counselor. And just, it was a really nice example of the ways to communicate with information to patients. And the last one here is that, I just like this last one because I think it really summarizes one of the issues in shared decision-making, which I mentioned earlier, that the idea that doctors and patients should agree, one isn't really, like the research doesn't really support that doctors and patients agree when something's informed or something's shared. But this to me seems like a much better way to think about outcome in terms of shared decision-making than whether the two people involved are agreeing with each other. But that the decision made, that the doctor is understanding where the patient's coming from and understands why they're making a certain decision. So traditionally, as just a sort of quick summary of the results, you have on the left here is sort of how existing shared decision-making models work, and on the right is ours. So the first one, the target of the intervention is to reduce the informational asymmetry between doctors and patients. So really to like help patients understand what medical care, what are all the sort of nuances of medical care, and to increase this, so really focus on this one asymmetry. But we know that this is not the only aspect of doctor-patient interactions that where there is an imbalance in power. So for us, the ideas of increasing elements of support, empathy, and mutual trust to facilitate this kind of information sharing should be the target rather than the informational asymmetry itself. I've talked a little bit about this, but this definition of success is about an outcome and specifically a mutually agreed upon outcome, where we would define success much more in terms of process and quality of decision-making. Simply, the third one here is the focus of decision. So existing shared decision-making models tend to focus on decisions about the treatment, while relational ones, what we were seeing was that it was not just about the care, but what their person's everyday life and what it was like to accommodate for taking medications, having a certain condition, and living their day-to-day lives. And number 4 is, like I hinted out earlier, the relationship is often seen as important, like rapport building is important, but then it goes away. So the relationship becomes of secondary importance fairly early on. And for us, we conceptualize the relationship as something that's important throughout the entire process, right? And something that should be measured and paid attention to throughout the entire process. So I'm going to jump over. The thing I want to talk about is, so we had all these findings from our qualitative study, but we still want to sort of drill down and understand, sort of in terms of developing a tool, these things are still fairly abstract. And the idea here is that we wanted to get sort of a more on the ground items to put to sort of exemplify all of these different areas that we found. So we use this idea of this technique called concept mapping that I talked about earlier, and there's sort of two phases to it. In the first, you ask people fairly specific questions, as you can see here, about what sorts of things doctors and clinicians needed to do to help for a visit to go well, for someone to feel like they could be involved in decision making. And then you generate a ton of statements and behaviors and things that people could be doing. And we had a huge list, and we could get it down to about 100. I'm just going to show this. This is I don't mean for you to read all of this, but I highlighted some of the ones that stood out to me at the time. But as you see here, these are all sorts of things that are fairly clear, and there are things that you could measure and observe and do and make sure that are happening. So the idea here was to create a measure and a tool. And the way we saw it was to have both a client version and a clinician version. Many of the existing, or the one tool that exists for the last 20, 30 years comes out of this common factors idea that I talked about before. And it's a relationship inventory, and the way it works on the idea of convergence. So if the score isn't if patients feel like they like their therapist, they agree with how things are going, but more so how do the therapist and the client agree on the relationship. And we thought this would be important to keep. We would like to see this used as almost like a way to provide sort of ongoing feedback to both clients and patients about what's working and what's not working. So you can fill it out after sessions, or fill it out a couple times a year, and to get a sense of what's working and what's not working, which has been done in other fields and with pretty good success, like in psychotherapy. So I'm going to show you we've been piloting this tool and trying to refine some of the items. But this is what it overall looks like. But I want to walk you through each one in the next couple of minutes here, so you can get a sense of what it looks like. And I said that I want to focus on the client version of this, but I can give you some examples of what some physician questions might be. That would be basically the same, but with a different wording. So the first main area, and I think this is the one that really held everything together, was respect, right? So some of the most important items for people here. So I should say, we did these focus groups. People came in. We completed those, had this list, and then what we asked people to do is a different set of people to come back in and just start to sort these different items, those 100 items I showed you earlier, into groups that made sense for them, right? To get a sense of what the roadmap might look like. And this is what the roadmap looks like here. So all of these represent how that takes into account everyone who participated, how they sorted and how often they sorted things similarly, right? And these are the ones that came out the strongest. So the first one, and the one I think that holds everything together, is around respect. And I think this one is the most important thing throughout. Like, I think that's been important throughout this entire project is, I think while we often talk about respect, you'll can walk around any clinic, hospital, you'll see something about respecting patients. But in terms of how that actually plays out on the ground, I don't think we actually know. So some of these things were surprising. Like I heard this time and time again about feeling like their clinician enjoys what they do. And this was a very important thing to people. But then these are more, I think, make more sense. Like my clinician is truthful, my clinician is direct, my clinician is kind, my clinician is fair. Right. The clinician version would be sort of the flip side to this with a bit of a caveat, which is that I'm not as interested in if the doctor or clinician feels that they are being truthful, but whether the client thinks they are. So, for example, this third question, my clinician is direct, the clinician version might be something like, my client feels like I am being direct when communicating information, right? So to help put them in the shoes of their patient. The next one was consistency and dependability. So my clinician is consistent, my clinician is dependable, my clinician is honest about what they can and cannot do. I'm just going to go through these kind of quickly so we can leave time for questions. And as I said, we're refining some of these and finalizing this, but this is what we're looking at so far. The third one was around encouraging autonomy. So my clinician encouraged me to ask questions. My clinician does not argue with me. My clinician trusts what I have to say. This shouldn't be encouraged. My clinician celebrates my accomplishments. There's a mistake here, but that's what the last one's supposed to be. We did ask people to also, when they sorted them, to rank how important they were and how frequently they happened. So we tended to focus on things that clients felt were very important, but we didn't necessarily focus on things that were happening all the time. Because if they're already happening all the time, it's not necessarily something we need to fix. So we really tried to focus on the ones that are most important to clients and that may not be happening all the time. The next one, so there's encourages autonomy, but there's also encourages agency, which is, while they sound similar, they're slightly different. So my clinician lets me make my own decisions. My clinician made me feel like I could be honest with them. My clinician allowed me to talk. My clinician helps me understand. The next one was trust. So things like my clinician believes in me. They help me help myself. They look me in the eye. So you can see there's a range here in terms of what people were saying, and from attitudes to behaviors. So it really runs the gamut here. Caring was the next big group of questions. And this was something that came up all the time, was just that clinicians were interested in people's day-to-day lives. So my clinician asks how I'm doing was really important to people. My clinician cares about me, my clinician understanding, my clinician takes my problems seriously. The next one we called whole person. So my clinician takes care of everything I ask for, so it doesn't just focus on one thing. They listen to me, they know my history, they respect my confidentiality. The final one was competence and transparency. And I think this is not exactly how we would see competence from a clinician point of view, in terms of expertise and around delivering care, but it was around more relational factors. And these labels did come from the participants who participated in this phase. So things like my clinician calls me to see how I'm doing. My clinician's incompetent, knows what they're doing. They make concrete plans about treatment. They set reasonable expectations about treatment. So that's kind of like an overview of the tool. But what I'm really hoping is coming clear here is that I think we know that how important relationships are for in delivering care, but I think it's something that we can treat a bit more rigorously and include it in things like research and training and education, and do it in ways that we can measure and actually use. I mean, some of what we were seeing when I mentioned earlier, where there are these sort of attempts to tie shared decision-making to reimbursement, but we don't really have a good way to measure if shared decision-making is happening. So we need to sort of move the sort of bar up a bit. So I think there's a range of applicability here, from sort of larger policy kinds of things to the ways someone in the interactions people have in the consultation. So, but I think I'm going to leave it here, and we have about 15 minutes for discussion and questions.
Hi, I just wanted to remind people that if you do have any questions, you can raise your hand and say them out loud. Here, we can unmute you, or if you want, you can do it in the chat, or you can also ask after the webinar is over. If you would like to send us an email, I will put our email address in the chat right now. mhtpcnetwork.org. And feel free to always email us if you have any questions in regards to the presentation. If you have questions for Dr. Pavlo, just let us know.
Do I have one question in the chat here? Okay, there's a couple of questions here. I guess everyone can see these, right? So the first question is the relational tool something you devised from, I assume, from observation, or is this a tool used widely? No, this is something that we've been working to develop over the last couple of years. And we are still even just in the phase of just like refining questions. So the next phase would really be to try to implement it and see how, if it can be used and if it's helpful. So I hope that answers that first question. The second one, it says, just sharing from my own personal experience, having a strong rapport with my doctors helped me feel confident in making decisions on my own, and has also led me to leave doctors who I felt did not care. Yeah, I see the importance of today's information. Oh, good. I thought that was a question, but glad. Yeah, okay, so the next question is, I think, is a really important one. Is there a way to implement some of what you said to help families learn their boundaries and how to speak to the person about their illness? This is, I think, a really, really important issue when it comes to shared decision-making. So I think there's a couple. Shared decision-making, I think, because it's a much more sort of American Western concept, really tends to be about the doctor-patient dyad, right? To the exclusion of families, which we know that might be fine for some cultures, for some families, but that is not okay for families in general. And in particular, culturally, the idea of making a decision on one's own is something that often doesn't even make sense. I think we need to, shared decision-making really needs to, shared decision-making research really needs to start to address this issue. And I think it gets more complicated in terms of mental health care. People may not want their families involved, for one. Second, I think families often feel afraid of what's happening and may want to be more involved and possibly more in control, which may not be as helpful to the person. The one thing I can say in terms of something more concrete is really starting with the client and then moving to talking with the family about how everyone wants to be involved in decision-making. I think what often happens is that people talk about a client as if they're not even in the room when they're making a decision. So I see the next comment here, but the family, seriously mental need that family interaction. And I agree. I think that's really important. I think by engaging families and clients together rather than separately, or rather than not listening to one of those groups, would be important. I think this also there just needs to be more work around this area to think about how shared decision-making might work when so many people might be involved, right? Some clinicians might be really skilled at navigating that interaction while others may not, still leaving the person kind of left in the middle. So I hope, Marianne, I hope that answers your question. What else? Yeah, I think I agree. I agree with your comment here. I think everyone needs to be on the same page. To be honest, I think it's important for family members to be involved in care in ways that also feel okay to the client. Any more questions? I don't off the top of my head. So the question was, do you recommend a book for parents and guidelines for better dialogue? I assume you mean between family members in terms of better family members, the patient, the client, and the doctor in terms of a better dialogue. I don't know a book off the top of my head for parents, but I can take a look, and if you want to email me, I can get, I can send that. I can send you that, or we can just, yeah. Okay, if this is your last time. If there's anyone, if you have any more questions, we can talk about that now. If not, we can end today. Okay.
Thank you so much, Dr. Pavlo, for today's presentation. And I just want to bring everybody's attention to the chat. We did put in a link to an evaluation. It would be really helpful if you did fill that out. Your feedback is really important for us so we can continue to receive funding to provide these training and services. So if you could just go to that link on the chat and just fill it out very quickly, that would be very wonderful for us. And again, thank you so much, Dr. Pavlo, today for your presentation and for everybody for being here today.
Thanks for having me, and thanks everyone for coming.